Welcome everyone to today's webinar. We're so excited to see a lot of attendees showing up for this presentation. My name is Dr. Angela DeRosa, and I am a board certified internist with a fellowship in women's health. And you can see I've had a fairly eclectic career, but most notably have basically provided clinical care in this space in hormonal health and restorative medicine for 25 years. And have also had significant experience when teaching and lecturing, and most recently founding the organization Hormonal Health Institute, which is a training institute for clinicians who want to get into the hormonal space. But my most esteemed, I would believe, and most exciting role is as the medical director for Belmar Women's Health International and APS. So I always get to participate in these webinars, often doing them myself, but I'm always much more excited to watch other very talented and exceptionally bright folks like Michelle, who's going to be presenting today on compounding questions. So Michelle is just a wonderful pharmacist from PharmD, a doctor of pharmacy, and she received that degree from the University of Wisconsin-Madison School of Pharmacy. Go Cheeseheads for as I'm actually born in Wisconsin as well, so I have a fond place in my heart for Wisconsin. But she has been notably been practicing as a pharmacist in various roles, and currently as a pharmacist in charge for Women's Health International for the last 20 years. It's quite impressive. She's responsible for maintaining licensure and compliance with pharmacy laws and regulations in all 50 states, and currently holds 20 state RPH licenses. So she also just really loves doing educational seminars, but also providing one-on-one clinical discussion with colleagues and folks like yourself. So she's a wonderful, wonderful resource, and we're just delighted here today to have her present to you on this topic. So without further ado, Michelle, I'm going to turn it over to you.
Thank you, Dr. DeRosa. I appreciate the introduction, and thank you so much to everybody who has taken time out of their busy day to attend our seminar today. Much, much appreciated. I hope I'm able to answer some of your burning questions. So as Dr. DeRosa mentioned, I've been with the company for over 20 years. My first 10 years were as a staff pharmacist. And so I have heard many of the questions that patients and practitioners ask and was able to compile some of the most common. Let's start out with one of the more basic questions. What is pharmaceutical compounding? Pharmaceutical compounding is the combining of one or more active ingredients into a customized treatment for an individual patient's needs. And in my opinion, the most important words in this sentence are customized and individual. This is what compounding pharmacies strive to do, to make sure each person's individual needs are met. And as no two people are exactly alike, those needs will likely differ from person to person, even if they're really being treated for the same condition or medical concern. Why might somebody choose compounding, either patient or practitioner? I'm sure the list is very, very long, but here are a few examples that I can provide. We can add flavor to an oral liquid or sublingual lozenge or anything really that's being tasted in the mouth to make it more palatable for a child or for a pet. And as somebody that has a child and a cat and a dog at home, I can personally attest to the success in administering a medication that tastes good as opposed to one that is bitter and unpleasant. Compounding pharmacies can also combine multiple medications into one dosage form for convenience and improved adherence. And I'm sure you can imagine it is much easier for patients to take one capsule as opposed to 4 different capsules, especially if they sometimes forget to take their medications. Compounding pharmacies are able to provide alternate dosage forms for patients who can't take medications orally. Forms like creams, gels, topicals. We can also compound suppositories for vaginal and rectal use. We can compound sublingual medications. At Women's International, currently, we are a non-sterile compounder, but we are going to be branching out into sterile compounding. And at that point, we'll be able to provide other alternatives as well. We are very used to working with chemically sensitive patients, and we specifically use ingredients, inactive ingredients in our creams and gels and other dosage forms that are known that chemically sensitive patients can tolerate. And of course, chemically sensitive patients aren't always sure exactly what they're sensitive to. They just know that they react to a lot of different things. And so we are able to provide a lot of different options. Say that they react or they have a rash to our cream base. We have multiple different options for them to try, and we will find the right answer for them. Compounding pharmacies are also able to make minute dosing adjustments. So for example, if somebody is taking an estradiol tablet that is commercially available, perhaps there are 4 or 6 different strengths available. What happens if the patient needs something between 2 strengths? That is where a compounder can come in and make a great difference for the patient. One of the most common questions I hear is, why does compounding take so long? I can send my patient down to the retail store and they can pick up their prescription in 20 minutes. Well, I think it's important to picture what's happening in each type of pharmacy. A retail pharmacy on the corner of your local hometown, the way medications are filled there is the technician goes back and grabs a bottle off of the shelf, pours the tablets onto a tray, counts them out, puts them in a container, labels it, and there you go. Not to discount the clinical services that retail pharmacists are providing. The pharmacy service there is very important as well. However, in a compounding pharmacy, we are starting from scratch. We take the active ingredients and the inactive ingredients and combine them to make the medication specific to what the patient needs. And so, of course, that's going to take a little bit longer. There are differences between non-sterile and sterile medications as well. Non-sterile compounds include things like topical creams and gels, capsules, tablets that are taken by mouth, suppositories, even nasal sprays. However, sterile compounds such as pellets or injectables have different requirements, and they need to be sent out. Certain parts of the lot need to be sent out for testing before these can even be dispensed. And so, as you can imagine, there is a time involved there as well. One thing, if I can give you a hint, one thing you can do to reduce the time that it takes for your patient to receive a compounded medication is to make sure to submit a complete prescription with all elements. Those elements include the drug, the strength, the dosage form, directions for use, the quantity to be dispensed, any refills, the patient name, address, phone number, date of birth, and email address. And then, of course, your name, address, phone number, and if it's a controlled substance, your DEA number. That makes it so that we don't have to reach out to you to clarify any part of the prescription before we fill it. Additionally, I'll talk a little bit more about another possible requirement from the FDA in a few slides. Compounding pharmacies are held to stringent standards that are established by USP, the United States Pharmacopeia, which is a nonprofit organization that develops and publishes standards and related programs to help ensure the quality, safety, and benefit of medicines and foods. And so, of course, this is a good thing because you can rest assured that your patient is receiving a quality medication. However, some of these standards require processes that are quite involved and time intensive. So this adds to the compounding time as well. Some compounding related standards include USP 795 for non-sterile compounds, USP 797 for sterile preparations, and USP 800, which is related to hazardous drug handling in the healthcare settings. There are other standards as well that come into play, but these are the main ones that compounders are required to address. This is another frequent question that I get. What is the best dosage form? I want to make sure my patient gets the best dosage form. So which one is it? And in this situation, there is no one best option. Each dosage form has its place and has good and sometimes not so good associated with it. So for example, oral capsules and tablets are very convenient. All you have to do is remember to take them and off you go. However, it is more difficult to adjust the dose with an oral capsule or tablet because you're not able to use a partial capsule. like you might be able to in a different dosage form. Sublingual capsules, lozenges, and drops are often used when fast absorption is required. So sometimes if somebody might be using, say, PRN estrogen to treat a migraine, we often see drops used in that scenario so that the estrogen is absorbed very quickly. Topical creams, gels, and non-alcohol gels are beneficial because these dosage forms can be adjusted. We are able to dispense these particular forms in a dispenser that can measure a quarter dose, a half dose, a 3/4 dose, and a full dose. And so if a patient isn't quite stabilized on their dose yet, it may be that you would prescribe them a topical cream in this dispenser and have them start with a quarter dose and then adjust based on symptoms from there. Vaginal and rectal suppositories are generally used to treat symptoms in those specific areas. And then injectables and pellets are kind of a set it and forget it type of dosage form, which is really nice because you don't have to remember it every day. They need to be administered maybe somewhere between 1 week to once a month for injectables, and for pellets, somewhere between 1 and 3 months. Delivery devices are also a way that compounding pharmacies can really customize a medication for a patient. So if a patient is using something for vaginal use, we would send that in a tube with an applicator that they can use to apply the medication and also to help measure it. I mentioned previously that we include the topicals in a metered dose container. And what that looks like, it's a little bit like a deodorant dispenser where you turn a dial on the bottom and the dose comes out through holes in the top. And with the dispenser, it can actually be used as an applicator to apply the cream, which is really nice because then the patient doesn't have to worry about getting the hormones on their hands and perhaps transferring the hormones to other people. Syringes and droppers can be used to measure drops. So remember when I told you that I'd be talking about another way to get compounded medications to your patients faster? Well, here it is. We hear this question so frequently from practitioners. It is, what's the deal with the FDA's involvement in statements of clinical difference and why should we care? Excellent question. So if there is a drug on the market with the same strength and used by the same route of administration as the compounded medication prescribed, the compounding pharmacist is required by the FDA to obtain and document a statement of the significant clinical difference the compounded medication makes for the patient, for this specific individual patient, prior to compounding the medication. Otherwise, the compounded drug would be considered a copy of a commercially available manufactured drug, which is not allowed. And that, if the pharmacist would ignore this requirement, that would set them up for discipline either by their state boards of pharmacy or perhaps even by the FDA. And so let me give you an example of what this might look like. Say that you have a patient who has a peanut allergy. And so because the progesterone 100 milligram and 200 milligram capsules available commercially on the market are made in peanut oil, your patient isn't able to use that manufactured drug. We are able to compound the progesterone 100 milligram capsule, say, in olive oil. And so all you would have to do is just document on the prescription, on the hard copy, that the patient has a peanut oil allergy, and that would fulfill this requirement. Something else to keep in mind is that we are required to obtain this statement on every prescription. So if the prescription has refills on it, we can send the refills out without obtaining this statement. However, if the prescription needs to be renewed, even if we already have it on file that the patient has a peanut allergy and it's obvious why we're dispensing the compound, we need to have you document this information. And that is strictly by the FDA's requirements. Pharmacies and pharmacists are licensed and strictly regulated by their state boards of pharmacy. And this has always been the case, at least since regulations have come about, hundreds of years ago. Compounding is a core component of pharmacy, and it really always has been. This is how pharmacy started, was with compounding, each pharmacist making a medication for each patient that came in. And then eventually manufacturing came around and things changed. But compounding has always been subject to the oversight and monitoring of these agencies and the state. However, in 2013, the Drug Quality and Security Act was enacted. And this gave the FDA some authority over certain aspects of compounded prescriptions and medications at the federal level under the direction of Congress. So on to the next question. What is the best lab testing method to test hormone levels? In my opinion, each of these testing methods has their place. Here are my thoughts. I'll give you some benefits and some detractions for each. Blood testing has a very, very long history of use. It really is the gold standard. It has it's easy to access through clinic laboratories, and insurance often covers it. So that's certainly a bonus. However, keep in mind that with blood testing, this is just one moment in time. It doesn't necessarily tell you what's going on or what was going on 8 hours ago or 8 hours in the future. And so I do often recommend that if somebody is calling me and they have questions, they're saying that their levels are showing so high, but I'm not seeing those symptoms. At that time, it's a good idea maybe to retest and just see if you can determine what's going on. Additionally, timing from the last dose is important with blood testing. If you take the sample, say after 1 hour after the patient applied their cream, you're going to get a peak level, and that may not necessarily reflect what the average exposure to the hormones the patient is experiencing. Conversely, if you wait until 24 hours or 48 hours after the patient's last dose, you're going to get a trough level, and that may or may not reflect what the patient is actually experiencing. Generally, what I've seen is that practitioners will take the sample 6 to 8 hours after the patient has applied a dose, and that will provide kind of a general average as to what the patient's exposure is. After about 6 to 8 hours, the hormones move into the tissues, and so it's harder to detect them in the blood. With regard to urine, some positives are that it's a 24-hour survey of the hormones. So unlike the one moment in time from the blood testing, you're getting a full 24 hours of what this patient's hormones are looking like. Additionally, rather than just having the specific hormones, oftentimes urine testing allows us to look at the metabolites of those hormones as well. However, some negatives or some drawbacks of the urine testing is that it's inconvenient. Basically what happens is the patient is sent a large jug and they need to keep their urine collections for the 24 hours in question. And so inconvenient and, a little unpleasant as well. Additionally, it measures what has been eliminated from the body, not what is actually in the body. And sometimes those things are the same, but sometimes they're not. And so if you have somebody that perhaps they're a bit of a fast metabolizer when it comes to hormones, it may be that they're producing a lot of hormones and that's going to show in the urine, but because they're metabolizing the hormones so quickly, their levels in the body are actually quite low. Lastly, you can't really get information about hormones with any kind of a rhythmic release from the urine testing. You can get a total quantity, but you're not going to see that morning peak followed by a tapering off in the afternoon of a hormone like cortisol. Moving on to saliva. So some benefits with saliva testing is that usually you're getting 4 moments throughout the day. There are 4 collections that are required for a saliva test. And so this tends to be especially good for things like cortisol testing, because there you can capture that morning peak followed by the trailing off of the production. However, you cannot use sublingual dosage forms and use saliva testing because the sample is contaminated. Additionally, this method in particular is somewhat hotly debated within the industry. I've seen practitioners that use this specifically and solely to test their patients and adjust doses. And I've also heard from practitioners who haven't found saliva to work at all for them, and that they receive results that are not at all consistent with their patients' symptoms, and it's quite frustrating. So if you do choose to use this method, I think perhaps really keeping an eye on whether things are jiving between the levels and the symptoms, and perhaps using a fallback method, secondary method of testing as well. Next is the blood spot method. The benefits to this particular method is that, like the saliva testing, it's multiple test points throughout the day. The way that this works is the patient punctures their finger similar to how they would for a blood glucose test, and then applies the sample to a collection piece. And this allows the blood collected to be from the capillary. However, this is a relatively new method, and so normal ranges and methodology are still being established for this particular testing method. Some practitioners don't do any testing at all. And the pros here is that this method focuses solely on patient symptoms, which is of course what we should be treating. If the tests don't jive with the symptoms, we always need to be looking and seeing what's going on and why is that the case. I often think about stories that I've heard from patients who have had their TSH tested, and maybe it was high, and then they were started on some levothyroxine, and it came back into the normal range, but they're still feeling terrible. And so in that case, even though the lab test is normal, we still need to investigate further and find out what's going on for that patient. With no testing at all, I really feel strongly that at least a baseline test should be done, and perhaps a test as the person is reaching a balance on the hormones that they're using, and then perhaps annually ongoing, just to make sure that we're not ending up with levels that are too high or too low unknowingly. And it's another way to detect changes too. Perhaps you would see changes in levels before the patient would actually experience symptoms. And so then you could keep that in mind going forward and think about how you might want to make some adjustments once that's necessary for the patient. How do I get better prices for my patients? So of course, each patient is an individual. Sometimes their financial considerations are large, and sometimes they're not as concerned. But here are some ways that if you have patients who are struggling to afford their medications, here are some changes that might be able to be made to assist and to lower the pricing. As we talked about before, combining multiple ingredients into one capsule might be a possibility. Of course, then they all need to be taken at the same time, which might not always be appropriate. But if the patient is going between not being able to afford their medication at all and using 4 medications all at the same time, that this would be perhaps an appropriate option. Consider trying once daily dosing instead of multiple times per day. And I think you'll know pretty quickly if the patient's able to tolerate. Generally, they would experience breakthrough symptoms during the second half of the day if they need twice daily dosing. And again, here's an example of perhaps if the patient isn't able to afford their medication at all, once daily dosing is better than nothing. Consider changing to a less expensive dosage form. Certain dosage forms are more expensive and less expensive than others. Topical creams and gels tend to be less expensive than capsules. Consider getting 3 months at a time for a slight discount, although I would caution on this to make sure the patient is at least somewhat stable on their dose before going with a 3-month supply. Otherwise, they may end up with a whole lot of medication that they're not able to use. And then lastly, with topical creams and gels, sometimes, depending on what the concentration is, we're able to double the concentration and allow the patient to use half the amount. So this provides them the same dose. However, they're receiving a smaller quantity of the medication, which is less expensive. This is one of my favorite slides. I just want to point out to everybody here on the call that we as pharmacists are here to support you and your patients. This is what we love about our careers. This is why we do it. And so any questions you have, please call us. We have very experienced pharmacists here who can answer whatever questions you have, or if your patients have questions, please send them our way. We are more than happy to speak with them. We love to speak with them. Lastly, how to use a compounding pharmacy. We are really no different in this respect than any other pharmacy. We can accept prescriptions by fax, phone, mail. We can accept electronic prescriptions. And so if you are sending over a prescription and maybe you're not sure about the dosing or the form, want to kind of run some things by a pharmacist, please give us a call. As I said before, we are here to help you. And that is the end of my presentation. I am happy to field questions here. And then I've also provided my email address if you want to reach out to me directly. I would love to hear from you.
Okay, thank you so much, Michelle. So we're open for questions at this time. You can just enter them into the chat box under the Q&A. That would be fantastic. We do have some questions for you, Michelle. First off, if different routes of testosterone administration, troches, creams, gels, shots, are there any advantages to one over another? I mean, I clinically have my thoughts and opinions, but I would love to hear yours, Michelle.
Sure, yeah, but I'll be curious to see if I'm sure we're on the same page. You know, I think that in this situation, it really is a patient-specific experience as well. Each one of those might be appropriate depending on the situation. I've heard of situations where practitioners have prescribed lozenges or sublingual multiple times throughout the day, trying to kind of pulse the testosterone because the sublingual is absorbed more quickly. And sometimes that is something I've seen. With regard to the injections, I think it is important to make sure that the dosing is appropriate. If the dose goes too high and then comes back and goes too low, sometimes you see a conversion into DHT or estrogen. And so you need to consider, I guess, with the estrogen aromatase inhibitors, in those situations, just to make sure. I guess I would kind of keep an eye on estrogen levels there. And then with regard to the topical, I think that's a great dosage form. However, there may be situations where that's not appropriate. Perhaps you have young children at home and you're not able to prevent the transfer to of the cream or the topical to your children or perhaps to your spouse. And so in those situations, the injectable or something that wouldn't be applied to the skin would be more appropriate.
And I think those are all excellent and valid points. And really to kind of parlay on top of that, one of the things I always look at is, I know women's largely compounds for women, but we also have to consider half of our population of males. And typically when you look at clinical efficacy and different things, when I look at, so for instance, with men, pellet therapy is always a great and optimal therapy. I know that doesn't fall under the direct 503A compounding, but pellet therapies offer a really nice, smooth, steady state, both for men and women, and typically for hormones tend to be at the top, one of the tops for gold standards for hormone delivery. But then when you look at women in particular, I found clinically younger women seem to do much better with fast burst sublinguals or the troches or mini troches, since they have the sublingual absorption. And I think that's a great second best for women. I have seen that somehow little old ladies love the creams for some reason. I don't know what's going on with that generationally, but they tend to enjoy the creams. But Michelle, you bring up incredibly valid points about transference that really need to be taken into consideration. And then for the males, certainly injectables tend to be the next second best. They don't seem to perform as well with creams, gels, or troches. Troches get pretty large. They're very bitter. And the creams, they just don't seem to get adequate levels. So if I were triaging it, I would start with pellets for both, fast burst sublinguals for women as the next, creams as probably, they just don't absorb as well and provide great clinical result as far as, at least in my opinion. I see about a 20 to 30% efficacy with creams, about a 50 to 60 with fast burst sublinguals, and then with pellets closer to 80 to 100%. So I think there's definitely clinical benefits depending on the patient population, but also you have to take into concern the patient's cost structure and what they can afford, as well as what they desire. But as long as it's, in my opinion, non-oral, because the orals process the liver and kick out the clotting factors, all of those are going to be safe, and then it just becomes about patient preference. All right, next question for you is intravaginal hormone absorption better than topical for systemic hormone therapy?
That's a really good question. I think Dr. DeRosa, I'll be interested to hear your take on this as well. I've heard differing opinions from practitioners. I've heard from some that the absorption is better, and that all hormones should be absorbed or should be administered vaginally. On the other hand, there are studies supporting the use of low-dose vaginal creams for vaginal atrophy and dryness, and they find that those aren't really absorbed systemically, or at least not to any great degree. So I don't tend to recommend vaginal dosing for systemic use, but that is just what I've seen over my time here at the pharmacy.
Yes, I totally agree with you, Michelle. When you look at actually the research, the reason why even in some breast cancer, even in our breast cancer patients, you can use low dose, say for instance, estradiol or estriol, because it doesn't have any considerable systemic absorption, which you would want to avoid in that patient population. So there's considerable data when you look at those low dose formulations, they don't achieve systemic absorption, or if it is, it's very, very minimal. But I've also seen other literature where a lot of that becomes dose dependent. So if the doses become much higher and you're delivering it vaginally, then they can achieve systemic levels. But as far as I totally agree with you, I've never been one to want to recommend intravaginal hormones for systemic absorption. I just have better options, such as the fast burst sublinguals and creams systemically, instead of, because it can get also pretty messy when you're trying to apply things in that manner. So I just have found that patients don't like it, and I just don't like you really have to work on figuring out where that dose dependent kind of relationship occurs with those particular patients. And I just think it gets much more complicated than it needs to be. But to reiterate the point though, the low dose estradiols can be great for the vaginitis, vaginosis, and different things that are occurring from estrogen deficiency in the vaginal wall. And also, for instance, you can use intravaginal Valium for vaginitis and different things to help with that stays locally. Also, you can use the progesterone creams for protecting the uterine lining, but it has to be a certain dose point in order to show that effect. So it's really, you have to be cautious when you're using those and knowing what you're really doing and why and what you're trying to achieve and the goal of that. So I just think it can be problematic. There are much, much better options.
Mm-hmm. Yes.
So let's see if any other questions are coming in. I know that you kind of talked about troches and what they are and how to use them. Would you compare and contrast the troche and the fast burst sublingual and how those might differ a bit?
Sure. Yeah. So the fast burst sublingual dissolves very quickly, and there's less time that the medication is there in the mouth. The lozenge tends to dissolve slowly over time, and so there's more exposure there to the sublingual tissue when you're using a lozenge. And so both, I think, have their place, but they definitely are different.
So another question is, what benefit risks in continuing low dose bioidentical hormone therapy into patients' 70s? I don't know if you want me to field that one, or do you want to take that, Michelle?
Sure. I can start just by saying I think it's a matter of what the patient's goals are and what they hope to gain from treatment. I've certainly spoken with women well into their 80s and 90s, and I think I've even had a couple of patients in their hundreds who are still using the hormones, and they tell me that they've aged better and more comfortably than a lot of their friends who aren't using the hormones. So that's my experience.
All right, and I think when you look at risk benefits, you're absolutely right. You got to look at the individual patient. So, I mean, the way I look at, I know they have the ACOOG and the conventional thinking, which in my opinion is completely off base on this. They always say shortest amount of time, lowest dose, which is completely counterintuitive to the whole way of practicing when you're looking at optimizing patients' health so their bodies have the proper tools to function. And as long as the patient is healthy and active and otherwise living a good life, why wouldn't you continue those hormones well into those older ages? Now, if you have someone who's had a massive stroke or has significant Alzheimer's and they're bedbound and they have no quality of life, I mean, do you really need to be continuing hormones in those patients? Probably not, but hormones are essential for function. And a lot of it becomes about, you look at a lot of the research and talking about the early benefit, late harm, and in particular that applies to estradiol, is that if you start estrogens within the 10 years of menopause, those patients derive great benefit from a cardiovascular standpoint and overall mortality and risk reduction. Where it becomes a little more dicey is when patients are 10 years removed from menopause. So that 70-year-old patient in this question you're talking about, if it's a new start, that could potentially put that patient at risk, in particular for the first 1 to 3 years. And why that happens is, if the endothelium is not being exposed to estrogen, it becomes more cracked and develops more plaques and hardened. So that's why patients without estrogen start to develop hypertension. They start to see more cholesterol problems and increase in cardiovascular plaquing, which then puts those patients at risk for rupture and heart attack. Now, when you have that occurring over, let's say, decades, those arteries are becoming damaged. And depending on the other risk factors, such as smoking, diabetes, and various other things, that damage can be considerable. Now, if I start estrogen's going to go in and start doing the job it's expected to. It's going to go and want to repair that endothelium and try to make it more pliable and less plaque. But during that repair process, you put that patient at risk for cardiovascular events because they're more likely to rupture during that first year. Now, if they get past year 3, then what you start to see in the data is that actually they go back to baseline risk. And then in fact, by year 5, they have a lowered cardiovascular risk once again. But that first year is really problematic. So the approach that I usually take is I would attempt to try to treat that patient with testosterone, because that process is not going to be in play. And all patients, regardless of what age, unless there's some significant contraindication to testosterone, such as untreated sleep apnea or a testosterone tumor, most patients can do well starting testosterone at any point in their lifetime. Estrogen, you have to be considerably cautious with, depending on the timing of it. So, so I typically, if this 70-year-old came in, I would probably start her on a testosterone preparation. I would probably put her on a vaginal estrogen if that's required, and see how she does. And most patients are going to do very, very well with that combination and not require going on to estrogen. And I can safely do that without increasing their risk. So that's typically kind of the approach that I've taken. So another question is coming in, is that, do you have a preferred delivery method for testosterone in patients, especially in patients with very low progesterone levels? Michelle, do you want to start, or do you want me to jump in?
Especially in patients, what was the last part?
Very low progesterone levels.
Oh, very low progesterone levels.
This is a trick question, by the way.
Yes. Well, in my experience, I've seen progesterone used as an aromatase inhibitor and also a 5-alpha reductase inhibitor. So if they have very, very low progesterone levels, I guess I would probably want to see a little bit of progesterone added to the testosterone dose that they're going to be using, just to prevent any of that testosterone from kind of toppling over into estrogen or 5-alpha hydroxy testosterone. And so with regard to dosage form, I think that goes back to patient preference, and also just kind of the discussion that we had before about pellets, injectables, creams, and that type of thing.
So I have very strong opinions about this. I'm going to go Some people may disagree with me on this, so I'm going to put that out there right up front. But whenever you're delivering progesterone, you have to ask what is the indication that you're using it for. So for instance, if I'm using it to protect the endometrial lining, let's say a patient's on estrogen and they're postmenopausal and you need to ensure that they don't develop uterine cancer, the only proven and data specific studied and a gold standard is you have to have an oral progesterone therapy. It's the only research that is proven, with the exception of the commercially available progesterone cream that at the really, really high dose. Those are the orals and that particular progesterone cream have shown that it is capable of protecting the uterine lining from developing uterine cancer. Now, I know a lot of patients want to take progesterone in a troche or in a cream, but the problem with those is you get variable absorption levels. And if the patient developed uterine cancer, you're going to be SOL because you have to be able to go with the standard of care. And the minimum is an oral progesterone at 100 milligrams to protect for that indication. So I'm always using the progesterone compounded 100 milligram or a permethrin if you prefer commercially available. But you have to hit that minimum standard if the patient has the uterus. Now, if they don't, progesterone can often be added to protocols and say a low dose, like a 50 milligram instant release, if you want to help the patient with sleep or some anxiety. But again, with that uterus, you've got to hit that standard of care. Now, the other thing that you can use progesterone in patients with infertility and various other things, but that's a whole other topic outside of this discussion. Now, the reason why this became a trick question, and this is where some people may disagree with me, but I have some really good logic, at least in my opinion, logical explanation for it. When you're checking progesterone levels, you need to understand if the patient is premenopausal, that 1/2 of the month, so in the follicular phase, it is supposed to be low. It's because that is the estrogen phase and the follicular phase where the body is kicking out FSH to be able to drive follicular maturation for an egg. It's using estradiol and increasing that to be able to stimulate the LH surge so that you ovulate. But during those first 2 weeks of the menstrual cycle, progesterone is not active. It only becomes active after you ovulate and the corpus luteum starts to secrete progesterone. So it's that 2-week pre-menses, so that PMS time that progesterone kicks in, and progesterone levels are going to be markedly higher then. And then the body is using progesterone to prepare the body for pregnancy. So progesterone is going to help us hydrate, so it makes us retain water. It's going to want to hydrate, feed a baby, so it's going to make us crave sugar. It's going to want us to slow down to care for a baby, so it's going to make us tired. So progesterone has a purpose, even though we don't like the way it makes us feel. So in those premenopausal women, and this is the mistake I see providers make all the time, is they draw a blood level and let progesterone comes back low and they go, oh my gosh, you need progesterone. Well, if it's drawn in the follicular phase, it's normal. It's supposed to be low. And if you draw it and then the other mistake is I see providers draw it in the luteal phase and they go, oh my God, your progesterone's way too high and we got to rebalance your hormones and add more estrogen. So you have to understand the levels you're looking at. And in postmenopausal women, because the ovary is no longer working, progesterone is going to be low. It's supposed to be. And I see a lot of practitioners chasing progesterone levels to try to make people feel, or to try to drive a blood level, when in fact, you don't need progesterone unless you have a uterus. And the only way you should be dosing that is in order to achieve the uterine protection. Now, I know there's a lot of folks out there who think that there needs to be balance between progesterone and some of the things that progesterone provides for us. And I respectfully agree to disagree. And I have arguments with a lot of my very close friends who are experts on this as well. And we just have a disagreement of opinion. Now, in premenopausal women, where I use progesterone is if the patient is anovulatory or having anovulatory cycles. You can use it in a cyclic fashion, say day 14 to 28, in order to induce a menstrual cycle so they don't become at risk for that endometrial cancer. Also, progesterone, keep in mind, I'm not talking about your infertility patient. In fertility, it's very valuable to check progesterone levels at certain times in the cycle and various things, but I'm talking standard hormone replacement therapy. So be cautious when you're looking at those progesterone levels, that you know when they're being drawn in the patient's cycle and if that's supposed to be normal in the premenopausal women. And be careful using too much progesterone just because you're driving a level. Those can make patients feel pretty lousy. They can get fat and they don't like that. They don't like putting on the weight. They can get depressed and they can get very, very fatigued. And so you want to use the lowest amount in order to achieve the clinical benefit. Just my 2 cents. And again, I know some people may not agree with me. So. All right, we have another question. If dosing topical E2, so estradiol, 2 to 3 times per week, is it okay to use progesterone 100 milligrams on days estrogen used, or does it need to be used daily for uterine protection? Michelle, do you want to try? Or you want me to jump in?
So I think that you would address that.
Yeah, so I mean,
your feelings are that it should be oral and not topical, right?
Yes, it should be oral, but using the question, so I think what they're suggesting is if you're only dosing estradiol, let's say a couple times a week, can you only use that progesterone on those days? And in fact, the answer is no, you can't. If it's postmenopausal, if this is a postmenopausal woman and you're using any estradiol or any estrogen whatsoever, I don't care if it's the lowest dose possible, only 1 day a week. You've got to protect that uterine lining, and if something happens, you will have to explain yourself, and you don't want to have to do that. And really, when you look at topical dosing of estradiol, to use it 2 to 3 times a week, I mean, in some patients, that's okay because estradiol does start to store in adipose, and you could probably get some symptom relief, but it's typically designed to be daily. But so testosterone won't work that way because it will be out of the system too quickly because it doesn't store in adipose. But the estradiol, you probably could get away with doing it that way, but definitely protect that uterine lining. I'm not seeing any other questions coming in. And I think we're good on time. Okay. Well, we appreciate everybody joining us for today. And Michelle, I really appreciate all your insight and knowledge. I'm sure everyone on the webinar found it incredibly helpful and valuable. And as you can see, you have Michelle's email address here, and you can also reach out to your representative that you work with directly. But she is a wealth of information, and we're here to help assist you in any way we can. And Michelle, thank you so much for your time. And thank you to everyone who participated today, and we hope you have a great day.